vaccines and COVID-19 and the spread thereof. Well, we are told a cold snap is looming, and it's bringing with it fears of a third COVID-19 wave. Experts say this winter will be bitterly cold, particularly in Gauteng and the Northwest. This could lead to an increase in COVID-19 infections, or could it? To discuss this, we are joined by health expert Professor Alex van Den Heever from the Wits University, University of the Witwatersrand. So I'm totally confused, Prof. And I imagine that many people are, because instinctively, I suppose, there's a temptation to liken COVID-19, the virus, and how it spreads and how it behaves in some respects to the influenza virus. And, you know, people tend to think it gets colder and people are infected more and more. But it seems even the scientific community is not settled on this question. What's the latest thinking?
Essentially, the COVID-19 sort of virus spreads largely due to human behavior rather than to weather directly, but it does spread indirectly due to weather. So the tendency for people to socialize in poorly ventilated indoor spaces during winter does create a significant increased risk of spread. There are a number of variables that can affect what happens this year, and one of them will be the number of people who have been infected before and may have a degree of immunity against reinfection. We're not entirely sure about the extent of that or the effectiveness of that in relation to new variants. But I think that we have to be incredibly cautious going into this period, because people are just going to naturally congregate in indoor settings. And taxis drive with windows down, buses with windows down. All of those will contribute to super spreading. And it's very clear that it's super spreading events that tend to drive infection rates, not the cold particularly. The cold is not activating the virus differently to warm weather.
Sure. So in as far as the virus itself and its makeup and the fatty layers and protein that surrounds the virus, there are no comparisons that can be made to the influenza virus that perhaps help to preserve its structural integrity even at cooler temperatures, or are they?
Well, so if we had to look at flu is also transmitted due to human behavior. So again, the association with cold weather is akin to that for COVID. And that is that people will congregate. And if it's airborne, that's where the transmission is most likely to occur. So there does not appear to be a lot of evidence that suggests that this virus behaves differently in cold, or you have greater protective effect in warm weather in relation to being infected or to a more severe infection. It's largely due to the human scenarios that are impacted by cold weather. And we saw that during summer, we had a massive second wave that during the hottest period of the year. And that clearly was related to super spreading events when people became incautious during that period. So I think that last year we started to see the uptick, the first wave, the dramatic uptick in the first wave, probably for an equivalent period, it would be sort of the beginning of May, and with signs of it during the end of it, toward the end of April. But that was the period that we saw the rise occurring initially first in the Western Cape. So I think we have to watch very carefully about what happens now going into this period. It's quite possible that our behavior is considerably different to what it was in April last year, even though we had the lockdown during that period, April, May, June. But that is going to be our high-risk period.
Yeah, and that's a good point that you make there, and the reminder there, Prof, that we did see a massive second wave during the summer months. So in as far as that conversation around weather and time of year is concerned. But now let me ask you, given what we've seen of the spread and transmission in communities of the virus at the moment, and also relating that to where we stand in as far as vaccination is concerned and factoring in the variant first detected in South Africa and how that has become the dominant variant in this country. What's your feeling about the potential for a third wave?
Well, I think it's concerning that we don't have the vaccine rollout as yet. And even if we begin to roll out, it's going to be at a relatively low scale as the teething problems will emerge as we begin. Now, I'm not talking about the eNCA trial expansion, but the actual rollout, which we haven't seen yet. There is no rollout as it exists at this point. So we've probably got a window of about 4 weeks before we would have a sort of a high-risk period. But I don't think we're going to have vaccines administered at anywhere near the scale required to impact on that, other than to impact on the high-risk communities who are likely to develop severe illness. So I think that so the vaccine rollout is basically would potentially miss the third wave if we have one. But the risk of a third wave is uncertain. We're not seeing, a rise as yet, but we also didn't see very significant increases at this period last year. We saw rises. Anything that rose last year at this time was worrying, but we never really knew the scale of what was before us. So we know we're close to a kind of a surge equivalent to the first or the second wave at this point, but it doesn't mean it won't occur. So if you look now at India, which is also generally warmer weather, by the way, they are in dire straits. And the problem with India for the rest of the world is that the levels of transmission there are very high, and they're generating new variants. So the South African variant is one issue to be concerned about. But the other concern would be whether or not these new variants emerging in India and in other countries with very high prevalence, whether they're going to have a feedback effect on us even when we're vaccinated. So I think we've got a lot of unknowns going through this period. But what does appear to be the case is that the vaccines are impacting on severe illness, which really means that the vaccine programs need to expand. They may not prevent transmission in every instance, but they certainly will reduce the impact on hospitals and mortality.
So given what you just said, and as a last question to you, Prof, the expectation that we can start the second phase of vaccination, even though, as you point out, that technically that would really be the first phase of a rollout of the vaccine, because what we're dealing with now is not a rollout but an implementation study called Sisonke. But nevertheless, it's being characterized as the start of the second phase of vaccination around mid-May. How rapidly do we need to ramp it up to obviate some of what you've been talking about, some of the risks that you've been pointing to, and to try and at least get as close as possible to the trajectory that we had set for ourselves of vaccinating a good chunk of our population by the end of the year?
Well, if we begin in mid-May, we are really very far behind. And if you note the number of people who were indicated as having registered on the system, like 500,000 people, that is very low. We should be getting to a point where we vaccinated about 300,000 a day. So even to this point, we haven't registered a little more than what would be a day and a half's worth of vaccinations. So we're nowhere close to scale. We're also going to hit quite a lot of hitches in that a lot of people might not register in time, and the information system, which will be important to directing where vaccines go to prevent excessive queuing, and to make sure that people don't end up queuing and then finding out that they've run out of doses, is going to be critical for the information system to work, and it's not yet working as a system of organizing the vaccination strategy and process. So we have a long way to go. And we may need to consider actually allowing other groups to get vaccinated, just to get people vaccinated, even if they're not in the priority groups, if the people in the priority groups aren't actually arriving at the scale they should. But we have to vaccinate at the maximum number we can from mid-May. But I strongly suspect that we are not going to get anywhere near the 300,000 a day that we need during the course of May.
All right, Prof, thank you so much for your insights there. That's Professor Alex van den Heever, a health specialist from the University of the Witwatersrand. Staggering numbers that he's talking about, that at some point we need to get to a point where we are vaccinating some 300,000 people a day. To get anywhere close to the targets that we need to reach, to be able to reach a point where, you know, there's what they call herd immunity. I don't know if people still talk about that, but to get to a point where we've vaccinated a significant chunk of our population. Let's see how it all unfolds as soon as the vaccination programs resume and get underway in earnest.